Hello, Elizabeth. How are you?
Hey, Maville, I'm doing great today. How are you?
I'm also doing well. Thank you for asking. Thank you for joining us today. We just wanted to explore female health, and I know that you're a pro at this, and so I wanted to see if I could maybe pick your brain a little bit.
I'm looking forward to it.
Okay. So, if you could just begin by maybe telling us a little bit about yourself, that would be great. Um,
Sure.
yeah, just
So
your
I am,
background. Yeah.
I'm sorry, I didn't mean to interrupt, and I'm an Italian, so I'm going to talk a little bit with my hands. I hope that's not too distracting.
No,
Um,
that's great.
so I'm an OBGYN physician and surgeon by trade, and I have been in practice since I finished my residency training in San Diego in 2001. I've been serving in the United States Navy, and so I've been really blessed. I've had the opportunity to serve women all over the United States, as well as over on the island of Guam and again in Italy. And it's been really an amazing experience. I've had the opportunity to work in both small hospitals and then larger teaching academic facilities. So I've kind of had the opportunity to do the whole gamut. Working right now in a hospital where I have the opportunity to teach residents as well as still see patients in clinic and do surgeries and work on labor and delivery and get to experience the miracle of birth, which has been pretty amazing. My day
Wow.
job is a little different, but I've been able to keep my hands wet, so to speak, in women's health, and it's been an amazing career so far.
Wow. And it sounds like you're passionate about it.
I love it. I feel like I've been really called to the best job in the world. Some days I just thank God I get paid to do what I do. It's pretty amazing. And women, well, let's face it, women are pretty amazing. We're amazing creatures
Yeah.
from cradle to grave. And so, again, it's really just been my privilege and honor to take care of us.
Amazing. Well, thank you for giving us a little bit of your background. Let's jump right in. I want to ask you, do you see patients coming in for the same types of issues now as they were 10 years ago, or is it looking a little bit different in the recent years?
For the most part, the number one, I wouldn't say number one, but some of the top reasons that women come in are reproductive concerns, right? So young women and sometimes older women who have delayed childbearing because of career choices and because of just life just kind of happens
Right.
sometimes. And so reproductive concerns are a big thing that we do in OBGYN. Chronic pelvic pain is another one. And so that's a real thing. For some women, it's unfortunate that it starts as early as, soon after their very first period. For other women, it may not start to rear its ugly head until later in their reproductive years, but it can be debilitating. It can be only associated with their periods, or for some women, they have some degree of pelvic pain almost every day of their lives. And it really is a negative
Oh,
impact. It can interfere with their ability to work. It can interfere with their ability to have a good sexual relationship with their partner. It can interfere with their ability just to enjoy daily activities.
right.
And that pain can fluctuate in location as well as severity. And I think we're going to get into that a little bit more later on. But those two things, and then abnormal bleeding, right, is another big one. So
Wow.
most women in the United States will get their first period somewhere between the ages of 9. Believe it or not, it's getting younger and younger because we are
Wow.
so well
That
and
is
yet
young.
poorly. It is young. Could you imagine
Yeah.
being in fourth or fifth grade and having to take a pad to school? No,
That is.
misery. So
And
it can
why is that? Do we know why that is?
better nutrition and more fat and hormones in the food that we're eating is the big suspicion. And
Wow.
so those are some of the reasons why our women are getting their periods earlier and earlier. So those are probably the top concerns that I see for women. And then other things like just vaginal health. Vaginitis is really, really common. And the reasons for women to have that vary depending on what decade of life you're in. And I think we're going to get to that a little bit later as well.
Okay. Now, when you say pelvic pain, do you mean like period cramps, or I guess I've never heard of this before. Is it the bones that ache down there, or what do you mean when you say pelvic pain?
So it can start out as being just related to periods. And so the severity of discomfort that women have with their periods, either for the few days beforehand and then while they're bleeding, is typically the time frame. That varies widely between women. There are women who get debilitating menstrual cramps that can begin several days before their period that can, again, interfere with their ability to go to work or require them to take medication of some flavor. Other women, their period's a big surprise every month. They don't get a cramp, they don't bloat, they don't get mood swings, and we don't know why it's different from woman to woman. Is it a hormonal flux that's stronger in some women than others? Is it just the way your body is made? It's not really clear. And so it can start out just with your period pain, but then depending on whether or not you have an underlying condition or there's some anatomic difference between your uterus and someone else's. And what I mean by that is you can have growths in either the muscle of the uterus or the lining of the uterus called fibroids, which are almost never cancer, but they can cause abnormal heavy bleeding and pelvic pain, or whether you have a condition called endometriosis. That can also cause you to develop pain and infertility problems over the course of your lifetime. Now, some women have endometriosis and never have symptoms, never have a problem getting pregnant. Other women have very mild forms of the disease and have debilitating pain and cannot conceive on their own without the help of IVF. So for those of your listeners who don't know what endometriosis actually is, it's basically where the lining of your uterus that you normally shed with your period every month if you're not pregnant somehow gets outside of the uterus into your pelvis. And it can cause implants that are either on the outside of your uterus, on the outside of your ovaries and fallopian tubes, on your appendix. You can have implants that are kind of scattered throughout your pelvis on the lining of your abdomen, and it can even be on your bowel. Those implants are stimulated with hormonal, usually it's estrogen is the hormone that fluxes every month and peaks. And that can cause those implants to become more symptomatic. And so again, that's one of those conditions that women can have, and it can be debilitating. So pelvic pain can be because of endometriosis. It could be because you have fibroid uterus. And I've taken uteruses out of women that were, you can't see in my bottom hand, but that were bigger than a football. And then if you have an abnormal cyst on your ovary or both ovaries, that can also cause pelvic pain. So there's a gajillion reasons why women can have pelvic pain. Some of them are treatable with surgery or medication. Some of them are less amenable to the TLC that we try to throw at them.
So these fibroids, could I check myself for that? Or would it be something that I have to go in, because like I can feel my breasts and see, do a daily check. Do I have lumps? Can you do the same with that? Or is that something that comes up when you go see your gynecologist?
It would typically be something that would come up when you go to see your gynecologist. However, if your uterus gets big enough, sometimes you can feel it if you're lying on your back and you press down right below your belly button or above, depending on, again, how large it is. Or sometimes you can see it. It looks like you're pregnant. So if you're standing in front of a mirror and you've got like a sideways view, you can kind of look at your belly and see that there's a bulge, and it's not fat. It's actually, your uterus that's grown and expanded. Sometimes you can feel it's lumpy bumpy because those fibroids are kind of on the outside as opposed to the inside. Other times they're in the muscle part of the uterus, and the whole kind of outside contour may still seem smooth, but you got a bunch of fibroids growing on the inside.
Wow, that I had never heard of that. That is so interesting. And I guess I have girlfriends who say they're always bloated. I imagine maybe that's a symptom as well. Perhaps it could be confused for being bloated.
It could be, although the uterus doesn't typically shrink and or expand and then shrink back during your period, but you have a hormone that's also released during your cycle. It's called progesterone. And progesterone tends to be the hormone that's more associated with abdominal bloating and just that feeling of, that uncomfortable fullness that we can get with our periods sometimes. Some women will actually gain a significant amount of weight every time they go through that part of their cycle, and then they'll lose it again. And so they have this really marked weight fluctuation, and it's mostly just water weight. And sometimes these women can gain as much as 5 or even 10 pounds every month with their cycle, that then they drop again. And again, that's not true for all of us, but for some women, that is very true.
Wow. That is so interesting. And you said we don't know the root of this. There could be many factors as to why women get this.
Now, when you say this, do you mean endometriosis or fibroid or bloating or like everything?
Well, I guess fibroids and endometriosis.
So the fibroids themselves are just a muscle. They're smooth muscle tumors, which is what your uterus is made of. It's a smooth muscle. And they're tumors that grow inside from that smooth muscle, and they're almost never cancerous. So almost never means very rarely. About 1 in 10,000 women that has fibroids will end up with one that ends up being a leiomyosarcoma or a uterine cancer when the final pathology comes back, if we do remove the fibroids or we remove the uterus. The interesting thing about fibroids is up to 75% of all women will have fibroids by the time they either get a hysterectomy or go to the grave. So they're very, very common, but not all women will be symptomatic. And so typically, if they're just really small fibroids, depending on where they sit in your uterus, you may have them and never even know it. And then other women, of course, just depending on where they sit, can be very symptomatic with really heavy periods. Some women have to wear double protection, so a pad and a tampon at the same time, or 2 pads at the same time, and they'll still leak through. The good news is we have ways we can deal with those, even if you still want to bear children. So you would need something called a uterine sparing technique. So there are different ways we can kind of deal with that. So if you are listening to this and you are a woman who is having to use 2 pads at a time or a pad and a tampon at the same time, and you're still changing your stuff out and you're still having socially embarrassing leakage, please go see your gynecologist and figure out why that's happening for you.
Right. Okay. So that is not normal to have such a heavy period. It's an indicator of something going on.
Correct.
Okay. What if you can still get pregnant? I mean, can you still get pregnant and have those symptoms and have an underlying issue? Or because I guess in my mind, I always figure, well, I would only have an issue if I'm infertile. Does that make sense? Or it's possible you have fibroids, you can still get pregnant.
Yes.
Oh, okay.
Yeah. So this is the tricky thing. It's kind of like the relationship between smoking and lung cancer, right? So smoking doesn't necessarily, a lot of people who smoke are never going to get lung cancer, right? But we know it's a risk factor for lung cancer because almost all people that have lung cancer are smokers or former smokers, right? So it's an interesting thing with fibroids and endometriosis and infertility or reproductive capability is, the bottom line is probably, I'm going to just talk about infertility for a minute and then I'll wrap it back to endometriosis and the fibroids, if that's okay.
Yeah.
So for women that are actively trying to get pregnant, 85% of us, if we are having intercourse around the time we ovulate, and most of us are going to ovulate between cycle days 10 and 14, and that's assuming a 28 to 30 day, pretty regular monthly cycle, counting your very first day of your bleeding as cycle number 1, we're all going to ovulate somewhere between cycle days 10 and 14. So just timed intercourse around that time frame. 85% of us will be pregnant within a year, right? So it's that other 15% that might want to go see their gynecologist to say, hey, I've been trying to get pregnant for a year and I'm not knocked up. Like, what's going on? And there's a lot of different reasons for why that might be. That would be one time where your gynecologist would help figure out, do I have fibroids that might or might not be preventing me from getting pregnant? Do I have endometriosis? Do I have a tubal problem that's because of my endometriosis or because of a prior, maybe sexually transmitted disease that I had that I may not have even known I had, but it's destroyed my fallopian tubes. So there's all kind of different things that can contribute to infertility. But a lot of women, getting back to your original question that prompted my squirrel moment there, a lot of women may not even know they have issues until they have issues. Does that make sense?
Right.
So you may not ever have pain in your pelvis, and you may all of a sudden be 30 or 35 and you're like, okay, I'm married now and my career is pretty settled. I think I'm ready to grow a family. And I've been trying now for a year and I can't get pregnant. Then your doctor may do some procedures that would help delineate, oh, you have endometriosis. That's why you're having issues. Let's see what we can do to help you get pregnant despite the fact that you have endometriosis.
Right. Wow. Okay, so there could be signs and there could not be signs. So,
Yes, isn't that great?
right. So, I guess that leads me into one of my next questions, which is how much control do we have over this? For example, food. Is food sexist? Does it affect women differently? Does it affect men differently? Does what we ingest play a role in these issues? That was
So
like a loaded question, but
yeah,
I
so
guess I'm just wondering nutrition, how much of it plays, how much of it is a role in our health?
wow. So I hope you have like a few days for me to cover all of that. So, people have written entire books about the role that nutrition plays in your overall health and then in very specifically targeted areas for your health. And, we're learning new things every year about nutrition and how it pertains to reproductive health, on how celiac disease, for instance, can impact your ability to, feel normally, to be less stressed, to have regular periods. I mean, everything really is interconnected. And so
Right.
the role of autoimmune disease and how nutrition plays into helping to regulate that in the absence of any necessary medications, we're still learning. Every day we're learning new things. The interesting thing is that so first of all, you said, is food sexist? Sexist, food doesn't know any better. It's not sexist. It doesn't care whether a man is eating it or a woman is eating it. It's still
Right.
getting consumed, right?
Right.
But the interesting thing is that because we have different hormones, right? I mean, I am estrogen, progestin heavy. A man is testosterone heavy, but men have
Right.
estrogen and progesterone too. And we have testosterone, right? We just have completely different ratios. The truth is that those hormones help regulate our gut biology and our gut microbiome, I guess is the right word for it.
Right.
And so the different bacteria that we have in our gut that are going to help digest food differently and extract minerals and vitamins and all that differently, we know that there are differences in the way that men and women, their gut bacteria behaves. And so again, we're still learning more about that, but there are differences between the genders. The other thing that's really fascinating about men and women is we tend to think about food differently, and we tend to be drawn to or crave different foods. There was an interesting study that came out a few years ago, and I can be more specific in writing with you later if you need to quote the actual study. I don't remember now, but they were
Okay.
basically looking at if men and women have choices between high energy, nutrient and calorie dense foods, i.e. fat filled yummy foods, right? And maybe
Right.
more lean foods, do men and women tend to select differently based on their gender? And what they found was, yeah, it turns out women are more likely to
Interesting.
select high calorie, energy dense foods, and men are more likely to select leaner, less energy dense foods. And so that hormonally mediated? Is that socially mediated? Is that because
Right.
of your upbringing and what we are expected to eat? That's a
Right.
complicated answer. And so I don't have like a
Yeah.
real easy, quick one off for you. But
Right.
yes, the quick answer is yes. Men and women, their bodies, their brains, we are different, even though try so hard to say we're just the same. We're totally not from a biology standpoint. And we absolutely metabolize things differently.
Wow. How interesting. Even like you said, it's so complex. Is it because of nature? Is it because of nurture? We'll never know, I guess. I mean, that it could be studied forever. And I mean, maybe there are studies, and here I am.
Well, and it's probably like everything else, it's probably a really nice combination of both, right?
Right.
I mean, it's like
Right.
saying you have a proclivity for something, or you
Right.
have a family history. So you may be more likely to develop something or to choose something in life. But that doesn't
Right.
mean you're doomed to that choice or that health outcome, right? Because you can still
Right.
make choices that can guide your path and can guide your destiny, especially when it comes to your body.
Right. Wow. Well, thank you for that super informative answer. I'm going to move on to one of my next questions. If I keep looking off to the screen, I have a long list of notes I want to get to
No
through
worries.
with you, if you don't mind. I'm going to jump into vaginal health a little bit
Mhm.
and discharge and odors. Are they an indicator of something, of your health? if there's an odor, if there's not an odor, a discharge, the consistency of it. I know, I think I've heard about it, but can you just remind us what we should be looking out for, if we should be looking for anything?
Yeah. So let me just start by saying our vaginas are amazing places, right? They are able to have babies, they're able to engage in intercourse, and they're able to self-regulate, right? And so there's a lot more conversation now about discharge and odor than I think I've ever seen in my entire career. And every woman is worried that she has too much or too little, that it's too thick or too thin, that it's not the right color. Like, why does it look yellowish right now when it always used to look very clear? You know, and what's this odor thing going? I mean, what are people talking about? Like, I should have an odor, I shouldn't have an odor. So the bottom line is your vagina has glands that produce substances that are wet, right? They do that for multiple different reasons, right? So during intercourse, their job is to make more lubrication so that it's pleasurable and not painful, right? They also secrete compounds and chemicals and to make sure that your biome is healthy within your vagina. So there's all kinds of wonderful little creatures living in your vagina, in all of our vaginas. Like right now, we've got a certain amount of yeast that live there very happily. You only have vaginal candidiasis or a yeast infection if that balance is upset and the yeast begin to overgrow all of the other little bacteria in there, right? You've got a certain amount of other bacteria, and the ones that are the most healthy are the lactobacillus, right? Those are the ones that keep our acidity in check and that make sure the others don't get out of balance. So sometimes when you take an antibiotic, you'll kill off some of those really healthy bacteria and those yeast can overgrow, which is why a lot of us, when we get antibiotics for a sinus infection or a UTI, all of a sudden we're like, dang, my vagina itches. Like, what's going on with that? And so that's just because things are out of balance. And so you need to treat that as well. So discharge is absolutely normal, right?
Okay.
You're going to have discharge. And the truth is that before you have babies and as you enter into different decades of life and after you have babies, and then when you go to menopause, you know, your vaginal discharge, both the consistency, the quantity, you know, is it heavier or thinner during different times of the month? That's all going to be a very dynamic, ever-changing story for each one of us individually. And we all know that if we're out and we're exercising, not only are we sweatier, but we have more vaginal discharge. It's just kind of part of being a woman, right? Every one of us also has our own unique physiologic odor, right? So it's normal for your vagina to have an odor. It's not normal for your vagina to stink and for someone across the room to say, "Ooh, what's that smell?" Right? We should be doing that. Right. And there are some odors that can be indicative that you do have an infection, right? And you need to get some treatment for that. The most classic one is BV, or bacterial vaginosis, which is not necessarily a classic sexually transmitted disease, but it can be transmitted partner to partner, and it's just an imbalance within your vaginal biome again. But typically it will smell kind of fishy, and especially after you've had sex, especially if your partner ejaculates inside, that chemical balance will mix with the chemical balance in your vagina with the BV, and it produces a really stinky, fishy odor, right? When you smell that, not okay, you probably need to go get treated for that, all right? But just having a discharge and having some odor, normal.
Right. So it sounds like unless it's really distinct or making an impression, it's normal and not something to worry about.
Correct.
Awesome. Noted. Okay. And then as far as pap smears, I feel like I've known so many people, girlfriends, who have gotten irregular pap smears. Is that normal? And then to go in and there's several different things. There's irregular pap smear, and then they want you to come back in and do further testing. And then what if there's bad cells? Does that mean that you have cervical cancer, or does it just mean that, you know, is that normal to sometimes have bad cells and not to worry about it?
So again, a really big question. So I'm just going to start at the beginning and talk about why do we even do pap smears? Like, why do we care? And so Dr. Papanicolaou, back in the, I want to say the 40s or the 50s, realized that there was a way to help screen women for abnormal cells on their cancer, on their cervix rather, because we know that certain types of abnormal cells could potentially lead to cancer. But if we could catch them early enough, we could do some treatments. Usually they're excisional, so we remove tissue, or we do a hysterectomy, depending on the extent, the type, et cetera, to save a life. That's the whole purpose of a screening test, is being able to define a disease that we can interfere with the disease process and prevent a bad outcome. Over the years, we realized that it wasn't just the abnormal cells, it was the presence of a virus, the human papillomavirus, that is a sexually transmitted disease. And that particular virus, it's a family that has probably over 100 different serotypes, right? But we've determined over time, and with looking at a lot of unfortunate women who have had these types of abnormal cells in the presence of this virus that we know have gone on to get certain types of cervical cancer, we now know that it's not just looking at the abnormal cells. We've been able to improve our screening by looking to see whether there's the presence of this virus, this HPV. And there are several different subtypes that are very specifically associated with cervical cancer, one type of cervical cancer. And so that's why we do the screening test. Now, we used to recommend as soon as you began having sex, you needed to start getting in to get your pap smear every single year. And we beat that into women's brains, right? So now I have women that are in their 50s and 60s, and I try to tell them, no, now that I've done this test and I've done the HPV, you don't need to come back and see me for 5 years. And they're like, oh no, you can't fool me. You told me for 30 years I had to do this every year, and I don't like it, but I'm coming every year because I'm not dying of cervical cancer. So we've gotten better at the recommendations. And so now we don't recommend that anybody, like 18-year-olds do not need to come in. It doesn't matter if they've been having sex since they were 15, because we know that if you're young and healthy, even if you are exposed to this virus, most young, healthy women will clear it over, the course of a year or two. You don't necessarily need anything done about it. So now the recommendation is when you're in your 20s, we recommend that you come in for your first pap smear, right? And we don't do the HPV testing until you get to be about 30 years old, roughly. So,
how interesting. That is the opposite of what I've heard.
Yes. Well, because sometimes when you have an abnormal pap on that very first, pap smear that you have, then depending on how old you are, depending on how abnormal the pap smear is, you might or might not need to go in for what's called a colposcopy. You might just be recommended to repeat your pap instead of in the usual 3 years that we now say you can do. You might be told to come back in 1 year. It just depends again. And there's a whole algorithm that goes with each one of the abnormal types of pap smears that you can have. And that's unique to your age and your pregnancy status, right? And those algorithms and those recommendations are put forth by, I want to say it's the American Society for Colposcopic, Surgeons. I'm not getting that acronym quite right, but it's close enough. It's the ASCCP. And they have amended those recommendations a couple of times in the last 10 years. So 10 years ago to now, we're not even treating women the same way that we did, because we know more now.
Right.
And so to your next question, what if I have abnormal pap smears? Well, number one, the good news is it does not necessarily mean you have cancer, right? And so because now there's an association between not just the abnormal pap, but whether or not you had the HPV and whether that was positive or negative, that directs the next step in your care. And so we might at that point again recommend a colpo or not. If you do end up going to colposcopy, that's what I would consider a little more invasive than a pap smear. So a colposcopy is where we take a special magnifying glass and we coat your cervix with a special solution. It can either be an iodine-based solution or a vinegar-based solution. Typically, it's a vinegar-based. So it's just white vinegar like you can buy off the store at the supermarket. It's a little more dilute than that, but it's the same stuff. It's just acetic acid. And what we do is we just basically paint your cervix with that. And any abnormal areas will highlight in a bright white color. And then we use a special green lens that shows them up to be even more different than the tissue around them. And that guides us to take a biopsy, which feels like a pinch, which that's not a really awesome area of your body to feel a pinch on, but it's pretty quick and it lets us get tissue. And then the tissue alerts us to whether or not you need anything more exciting done, right?
Right.
And that's something more exciting, might be a more invasive procedure where we actually remove a portion of the outside of your cervix. Okay. Um, so just having
That,
an
that
abnormal,
that sounds alarming. Is it alarming? Should someone start to worry if you get to that point where they're scraping, tissue to
well,
further diagnose something?
it sounds more alarming than it is. And the truth is that
Okay.
most women that have abnormal cells on their pap smears, even the ones that need to go to colposcopy, and even the ones that have abnormal cells on the tissue, they don't need a hysterectomy. They don't have cancer, but we need to pay more attention to them, and they need
Okay.
closer follow-up to make sure that they are not one of the less common women who progresses on to more severe cell type that needs, more aggressive action. And I will tell you, there are certain what we call modifiable risk factors for cervical cancer and certain unmodifiable risk factors. So you can't do anything about how old you are, right? But now there are two specific modifiable risk factors that you absolutely have control over. One of those is smoking, right? So smoking is absolutely associated with cervical cancer and abnormal pap smears,
Wow.
right?
Wow.
So if you're a smoker, please stop. It's really no good for you in any way, shape, or form, right? And then
What
the other
about
is
with smoking? I know that everyone has switched, or a lot of people have switched to juuling or
yeah.
vaping. Do you know if
So
that
don't get me
has the
started
same
on
effect?
vaping. Don't get me
Okay.
started on vaping. Honestly, vaping hasn't been around long enough for us to do any kind
Right.
of randomized control trials or even to do like a retrospective analysis. But I will
Right.
tell you, the stuff that's in vaping is basically heated wax. So when you inhale that into your lungs and then it resolidifies, it's just destroying you from the inside out. So if you really
Yeah.
want to spend your life, and we've had young people now that are, they have permanent pulmonary disease, fibrosis disease, and other things going on from vaping, which is supposed to be
Right.
safer, right? So
Right.
all it does is remove all of the tar and some of the carcinogens from cigarettes, but you're still getting the nicotine, which isn't necessarily good for your system. And you're still getting a whole lot of harsh chemicals that we don't even know yet all the damage that they're going to do.
Right.
So again, that's
Right.
my little PSA, my public service announcement.
Still not in the clear then if you're vaping.
No,
Yeah.
no.
Yeah.
And then the
Okay.
other modifiable risk factor is number of sexual partners, right? So it's one of those just really harsh realities of life that every single person that you have sex with, you basically are exposing yourself to every single person they had sex with and all
Right.
of the people those people had sex with. And
Right.
so it's kind of skeevy to think about, but hey, that's
Yeah.
the way it is. And so again, be happy, be healthy. But you only get one uterus, one cervix, and one vagina. So treat yourself like the queen that you are and protect yourself from those bad mamma jammas that are trying
Right.
to hurt you.
Wow. Okay. So no smoking, or, try to
Yes.
stop that bad habit if you have
Mhm.
that,
Yeah.
and try to limit the number of people that you're having fun with.
Yes.
Okay.
Yes.
Yeah. I mean, it all makes sense.
Yes.
All right. And then, I mean, I think we touched on periods a little bit earlier, but if we can just go over PMS. Are
Mm.
PMS symptoms? So I think some people, or, I've heard some sides of the story. Oh, PMS is made up in women's minds, or, they use
No
it as
woman
an
ever
excuse.
said that.
No. Is PMS real? Let's get to the bottom of that. Is it
Yeah.
real? And if it is it genetic, the cramping, the moodiness, or is it based on, I mean, again, I think it maybe is one of those things that it's just lots of things factor into it, nutrition and all of that. But what do we know about PMS and periods?
Yeah, so PMS, of course, stands for premenstrual syndrome, and then there's actually another syndrome that we've kind of defined or described called premenstrual dysphoric disorder, which is basically PMS, like to the moon, right? And so women that have PMDD tend to have severe mood disturbance that's just around the time of their period, that tends to not affect them the rest of the month, but it can still be like 10 days out of the month, which is, a third of your life as it turns out. So it still can be
Right.
pretty challenging to maintain relationships when you're, like a on wheels.
Right.
And so it's kind of hard, right?
Right.
So PMS symptoms vary widely, but the most commonly described are premenstrual cramping, some mood lability or irritability, bloating, abdominal bloating. Those are the most common. Some women will get an acne flare right before their period that will kind of subside a little bit after they've stopped bleeding as the hormones kind of settle back down.
Right.
So
Food
those are all,
cravings.
yes,
Yeah.
exactly. And again, when we are having those hormonal surges, we tend to be drawn more to energy dense, calorie rich
Right.
foods. That's kind of, again, hormonally mediated.
Right.
Now, just knowing that that happens doesn't mean you're a slave to your cravings, right? However, if you really feel like you need to eat a little bit more love food during that period of time, no pun intended, then just exercise a little more, right?
Right.
And exercise has actually been shown to help reduce the sensation of period cramps, along with Motrin, right? Um, and some women will try like over-the-counter diuretics as well to help with the bloating sensation. The interesting thing is that when women, so for women that have more significant PMS and they're not trying to get pregnant, there are several different oral contraceptive options and other birth control options that I might recommend to my patient who came in with those kind of symptoms, um, not for birth control, but to control menstrual flow, duration, and symptoms associated with that flow. So birth control pills are a great place to start. The issue with birth control pills is sometimes they can cause women to be more moody. Some women can even become more sad, depressed feeling when they're on certain birth control pills. So the great news is there's literally hundreds of different formulations of birth control pills. And so if your provider starts you on one to specifically treat either PMS or severe cramping or heavy flow, and you begin to feel like you're not quite yourself, you just go back
Right.
and you say, hey, this one's not working for me. Let's try a different one with a different progestin or a different concentration of estrogen, or maybe a pill that instead of being what we call a monophasic pill, so it gives you the same level of hormone all month long, instead there's a pill called a triphasic pill that gives you 3 weeks of 3 different concentrations basically of the estrogen so that it more mimics your own body's natural kind of flow during the month.
Right.
So that can sometimes help. There's also Depo-Provera, which you could inject. That's every 3 months. That tends to make most women what we call amenorrheic, which means you just don't bleed at all, right? So no bloating, no cramping, no bleeding. The issue with Depo is it can cause weight gain, but mainly because it's purely a progestin, and a progestin can increase your appetite, right? So when your appetite is increased, what do? You eat more, right?
Yeah.
So if you already know that's going to be a side effect and you're conscious of it, you can then put in some tricks in your life to help you not gain weight while you're on Depo. The other nasty side effect, it's not very common, but the other nasty side effect with Depo is some women will have alopecia or hair loss. Now, you're not going to go bald, but it's pretty disconcerting, especially if you've got a lush, beautiful
Yeah.
hair like you do, Maville, and all of a sudden
Oh,
you're pulling your
thank
hair
you.
out in clumps. That can be
Right.
depressing in and of itself, right? And then there are
Right.
a bunch of other things we can do to help make your periods lighter, and to help with those mood swings as well. So it just kind of depends on what symptoms you're having. And what I always tell
Yeah.
my patients is, if you're having these symptoms, but they don't really bother you, then don't worry about it. If they're
Right.
bothering you, then do something about it, right?
Right. Right.
But otherwise, I mean, having a period rarely killed anybody, right?
Right.
Um,
I
and
hope not.
so,
Yeah. Okay. And well, so this was a thought I always had, and I think with the pandemic,
mm,
schools, I think the silver lining of this pandemic, one of them has been that schools have actually started to look into mental health, and I know that some of them, dedicate certain days like Fridays to teachers can't assign homework, so that students get this break, and that they don't feel overwhelmed. And so they're taking mental health more into consideration. And that just makes me wonder, are there other, like PMS? Should PMS be taken into consideration? I mean, there's no right or wrong answer, but I mean, in your opinion, do you think it's a big enough issue to be an excusable absence. If someone has to call out for 3 days because they have headaches or, moodiness or, I mean, what do you think? Is that something that maybe schools should also look into, workplaces
Yeah.
as well?
That's really tough because that's really like a
Yeah.
social policy question, right?
Right.
Because there always are pros and
Right.
cons to having people not be physically present in the workplace, right?
Right.
So I really think that there are a lot of things that we need to do more for women in the workplace, right? More and more women are
Right.
in the workplace. We're still doing all the other things that women do, but we're different than men, right? We bear children. Men do not bear children. We have
Right.
periods every month. Men do not have periods every month. And most of the time, we are good to go even when we're having our period. But there are some months where some women are either exhausted, like some women, when they have their
Right.
period, it sucks the life out of them. And they literally
Right.
have a hard time getting out of bed, not because of mood issues, but their energy is so drained. Other women have migraines that are just triggered by that hormonal flux.
Right.
And so I think it's tricky because yes, I want to be able to say we need to accommodate that in our women's lives, right?
Right.
But then there's also an issue of productivity. So what do you do when that woman calls out sick? What are we doing to make sure that someone else is able to step into the breach so that we're able to allow that woman to do what she needs to
Right.
do, especially if we value her as a productive employee, right? We
Right.
want to be able to accommodate that because that's not really her fault, right? She has a uterus, she's gonna have a period every month, right?
Yeah. Right. Right.
And so how do we accommodate that in the workplace that is the right thing to do for that employee, but then also is the right thing to do for the other people in the workplace too? Because I'll tell you, the first thing the man is going to say is, well, I don't need to take 3 days off a month. So you're going to pay me more
Right.
money, or what are you going to do for that?
Right.
And so looking at how to make that fair and equitable across the board and still accommodate women, I think is a discussion that we need to start having. Absolutely.
Right, for sure. And it is tricky, because like you said, it opens up the conversation for men to say, well, I'll step in and I won't be absent for those 3 days every month.
Yeah.
So it is tricky. But I hope that it is a conversation that gets started. And hopefully, the more people that talk about it, the more that it can pick up some awareness and
Mhm.
that conversation can get some traction.
Yeah.
Um,
And
but
it's interesting too that we as mothers are raising a generation of men who I think are much more aware,
yes,
understanding, and able to be willing to step into that breach, understanding that the women in their lives and in their professional as well as personal lives are definitely value added, and that that's not
right,
a negative, it's just a fact of life.
right,
To
right,
kind of move beyond that. And so like
right,
one team, one fight, man, we're all in this together. And every
right,
man out there has a mother, right?
right,
And
right,
so some of them have wives, some of them don't. Some of them have
right,
sisters, so they're a little more kind of in tune. Others don't. But it's partly our responsibility to educate men on how important it is
totally,
to be open-minded and understanding and accepting, right?
totally, right. Well, thank you for sharing your opinion on that. I hope that we are moving in that direction, and I know that I'm trying to teach my son that. So, I mean, hopefully, it creates a domino effect if all of us women can unite and raise
Yeah.
just boys who are mindful and aware of facts of life like that. So,
Mm-hmm.
so anyway, I wanted to talk a little bit about COVID-19. Has it affected, how has it impacted your work, I
Mm.
should say?
Yeah. So it's pretty much initially it affected everything, right? So
Yeah.
I will bring you back to March, April of 2020 when we were just beginning to realize how international this was and how it was going to affect certain population folks. So I didn't say that very well. Certain facets or aspects of the population were going to be more affected than others. That knowledge kind of came as we went through. And so initially we didn't know how bad it was going to be. We didn't know who it was going to affect more than others. And so everything shut down, and that included healthcare, right? So all
Yeah.
elective surgeries were stopped. We were not admitting people for things that we would have admitted them for before, because we were trying to make sure that if we had this huge influx of COVID patients that were really sick and needed hospital beds, we would have the beds available for them. And if you have
Right.
people in the hospital for other stuff, then you can't, I mean, you can only have one person in a bed, right?
Right. Right.
And so initially it really affected how we were delivering care. We weren't seeing patients in clinic. We were trying to figure out how to scramble and figure out telehealth, which in a way, I think one of the good things that's going to come out of COVID is an understanding that every single patient that we see doesn't need to be in our office or in our clinic. Like there's a lot of stuff we can do by remote before we need to have people come in
Right.
to lay hands on them or do a procedure, right? So I think
Right.
that's going to change things a little bit, which is going to be good. So I see that kind of in the future being a
Right.
persistent good change.
Right.
The other thing that changed was, how did we comport ourselves in the hospitals? And initially, we weren't requiring everyone to wear masks. You remember the big mask controversy, right? First, it
Yeah.
was nobody needs to wear a mask. Then it was everybody needs to wear a mask. Then it was
Yeah.
back to nobody again. And now I think we've kind of settled on when do we need to have a mask on? When do we not need to have a mask on? But in the hospital, the rule is the minute you walk in the door, there's a mask on, and that mask does not come off until you leave the hospital. So
Wow.
and that's partly
Wow.
because the hospital is full of sick people, right?
Right.
So
Right.
and with COVID, it's all a numbers game. It's how much
Right.
inoculate are you exposed to in a way that you will be infected and then potentially, get the disease, get the infection, I should say.
Right.
And so initially it changed really how we were delivering care and what care we were delivering. But now that we've kind of gotten our hands around who are the vulnerable populations, what do we need to do to mitigate in which spaces? Like I don't need to wear a mask in my car. I don't need to wear a mask when I go out for a walk and I'm outside. But if I'm going to be in a meeting at work, or I'm going to be standing in a hallway with someone for a conversation, I probably need to have a mask on. If I'm in my
Right.
own office and there's nobody else around, I probably don't need to keep my mask on. But all
Right.
of these kind of practical things have changed behaviors that I think that they're going to be with us for a while too. Does that answer your question?
Yeah. No, it definitely does. And it makes me think of all the people who maybe are scared to go in too, how it's
Mhm.
impacted people's health on the other spectrum of, you know what, I feel some symptom, but I don't want to go get checked out
Yeah,
because what if I get something
yeah,
worse? I pick up COVID.
yeah. So
I
that has
mean,
definitely happened, and we weren't even talking about that too much in the medical community until probably June timeframe. And
yeah,
then all the cardiologists were like, "Hey, nobody's come in with a heart attack in the last 3 months. So I wonder if everyone's just all of a sudden healthier." I mean, of course, they knew everyone wasn't healthier, but
right.
emergency room visits dropped drastically. People that were having stroke symptoms weren't coming to the hospital. They were just at home dying of a
Wow.
stroke. People that were
Yeah,
having heart attack symptoms were not coming in. They were just at home dying of a heart attack. People
right.
that needed surgery for cancer were not getting their surgery for months. They were being told,
Wow.
nope, because we need to keep these beds open. We're not doing any elective surgery. And so, and then other people that were having symptoms consistent with the cancer maybe weren't going in or weren't able to be seen for months because of the way that the system was trying to mitigate COVID. And so we're just now starting to look at, well, what are those numbers and how do we measure them,
Right.
right? Because it's
Right.
kind of like trying to measure facts, not in evidence. You can't
Right.
say something didn't happen just because you didn't see it. It's really
Right.
hard to measure that. And the other huge issue, I'll segue back to your comments and questions about mental health earlier, but we have noticed a big surge in suicides, suicide related behaviors, deaths due to drug overdoses, alcohol consumption. All of those negative behaviors have
Right.
escalated in the last 6 months during COVID.
Right. Right.
People that had been sober for years all of a sudden are drinking or shooting up heroin again. And, nobody knows what those numbers are. But when you
Right.
start to look at the initial reports, they're not good.
Yeah. Yeah. And I mean, you think about just, drug overdoses. So,
Mhm.
or even just alcoholics, I believe the meetings are being held virtually now. And I mean, that's just not the same for everyone.
No.
So it really does have an impact on everyone and on really deep levels. So I hope
Mhm.
that we are reaching the end of this dark tunnel. And it looks like
Yeah.
we might be, and hopefully it's sooner than later. But lastly, if we can, we're kind of reaching the end of our time here, unfortunately. But what are some tips you have for preventative care? Because, like you mentioned earlier, I was under the impression go every year to get a pap smear, but now it seems like maybe not. So if you could just give us a few of your tips, that would be awesome.
So from a preventive care versus preventive self-care, and we'll talk about that in a minute.
Okay.
You don't need your first pap smear until you're in your early 20s, right? You don't need your first mammogram until you are 40 years old. And then every year or every other year till you hit 50, depends on which body you look at for that recommendation. Some of the folks recommend that you don't need your first mammogram until you're 50. But the American College of OBGYN, to which I belong, still says at 40 years old, you need your first one. Now, the caveat to that is if you are a woman whose mother or sister was diagnosed with breast cancer before the age of 40, then you, or even before the age of 50, you need to have your first mammogram 10 years before the age at which they were diagnosed. So for instance, if your mom was diagnosed with cancer, breast cancer at the age of 45, you need your first mammogram at the age of 35, and then every year after that. And so that's a good preventive measure. You need your first colonoscopy at the age of 50, unless you have a significant family history, or unless you have clinical symptoms which prompt a colonoscopy before the age of 50. And your primary care doctor will help you figure out if you are one of those people who does need something before the age of 50. So those are the big three things, especially from a women's healthcare perspective.
Right.
Self breast exams, if you're going to do them every month without fail, so your fingers know your own breast tissue, awesome. If you're one of those, like annual breast, exam warriors, don't bother. Because all you're going to do, especially if you have lumpy, bumpy breasts, is you're going to be like, oh my God, I have breast cancer.
Yeah.
And you're going to be anxious for no reason. But if you do it every month, do it in the shower when you're already wet and soapy, it's easier to slide your fingers across your skin. And then you are going to know your own breasts, so that if you do feel something different, then you can bring that to your primary care doc. And then if they feel like they need to refer you, they can refer you to a breast health specialist.
I see. Now, and sorry to interrupt, but
that's okay.
Since you're talking about lumps in your breasts, so it might be normal to feel some, but are there, is there a sign like, oh, if it's a really firm lump, you should be worried, or is it just case by case?
Yeah, so there definitely are some characteristics that could be more consistent with a cancer than just a benign, nothing to worry about, or a fibroadenoma, a fibroma, or just your own natural lumps and bumps. So a significant number of women will have fibrocystic tissue, which is just lumpy, bumpy breast tissue, right? It's just how we're made, and we just got it, right? It tends to be denser on a mammogram. Sometimes it's harder to delineate when we have that fibrocystic tissue. But if it's cancer, it's more likely to be painful. It's more likely to be hard, like a stone, than rubbery. Like most non-cancerous are going to be more rubbery. And it's also less likely to be mobile, right? So most of us have stuff, we can just roll around underneath the skin, it moves, etc. If it's a cancer, sometimes it will be stuck. It'll feel like it's stuck underneath your skin, or it's stuck in a spot and you can't really move it around. Those are all signs that it may be concerning. You might want to go see your doctor.
Amazing. Well, thank you for sharing all of your knowledge with us. And before we go, I want to do a quick speed round if we can, just on some myths. If you can tell us if it's true or false.
Sure.
Douching is never necessary.
Do it. It's horrible. Don't do it. Your vagina doesn't need it. Your vagina, matter of fact, you can jack up the natural balance in your vagina with douching. So don't do it.
Wow. Okay.
Ever.
I wonder
how
how did it ever even pick up? I feel like it was popular maybe a little more back in the day, but if it's never necessary, how did that even begin?
I think because someone somewhere told some woman that her vagina needed to smell like a tulip or a flower of some flavor. That's the only thing I can think of, because really it does more harm than good. And it's not good for your overall vaginal health or hygiene.
Interesting. Okay. Periods. You know what? Your periods syncing up with your girlfriends and your sisters. Is that true?
Usually that only happens when people live together for a prolonged period of time. So just being
Wow.
related to someone or just having a bestie that you hang out with a lot isn't enough. It's you usually have to live together. But for some women, that can definitely be a thing. Now, if
Wow.
you're on a birth control pill and your bestie is on a birth control pill and you're not synced up, then you're not all of a sudden going to sync.
Right.
But yes,
Don't break up with
can happen.
Yeah, don't break up with your girlfriend if it's not syncing up at the same
That's
time.
right.
You're
It doesn't
still
mean she
best
doesn't
friends.
really love you.
Yeah. Okay. And I mean, if you could tell us briefly why is that? Is that, I mean, that's a bizarre phenomenon to me.
Well, it's the power of hormones, and some would say it's the power of the
Wow.
moon. I'm not sure I quite go for that, but there definitely is some relationship between the moon and how women can fluctuate. And that's all I'm going to say about that. Let's leave it a little
Wow.
mystery, shall we?
Yeah, yeah. Breast cancer, you can't get it if you're young.
No, that's not
True or
true.
false?
It's less likely, but it's not true. And especially if you've got a strong family history of ovarian and breast cancer, and especially if the women that have had those cancers have been BRCA tested and are positive, you need to be uber cautious and definitely make sure you talk to your PCM about whether you need to be tested so you know what your risk factor is. And if you do feel something and you wait one full menstrual cycle and you feel it again, it hasn't gone away, seek care early. Better to seek care and have it be no big deal and a big nothing burger than to blow it off because you think, well, I'm only 25, that couldn't possibly be breast cancer. And then all of a sudden it is. So I say, if you're that concerned, go see your doctor.
Okay. True or false? You cannot get breast cancer if it does not run in your family.
That is not true either. Most women who get breast cancer do not have any family history of breast cancer.
Wow. Interesting.
Yep.
Eating and living a healthier lifestyle can relieve menopause symptoms. True or false?
Yeah. Wouldn't it be awesome if that were 100% true? So yeah, I would say that's hit or miss. And every woman does not go through menopause the same way, in much the same manner as not every woman experiences her periods the same way. So some women just stop having a period. They never have a hot flash. They never have a night sweat. They never get irritable. And then that's it. They just stop bleeding. Other women will hit kind of fits and starts with their periods. They'll start to space out, then they'll have regular periods again, and then they'll stop. Other women, they can have perimenopausal symptoms for up to 10 years before they finally hit menopause and they're done. So technically, menopause is 12 full months with no bleeding, right? Your ovaries have said, whoop, we're done. We're not doing this anymore. And so that's when we know you've gone through menopause, but just eating healthy doesn't necessarily mean your hot flashes are going to go away, sadly.
Right. What about exercising or just, overall eating better, exercising? Can you hope that that'll relieve some of the symptoms? Do you know if there's any studies on that?
It's not really going to help ameliorate or relieve your symptoms, but it is going to help you handle them better, right? So when your overall health is good, you're sleeping well, you have good physical health, you're well conditioned, you're putting good nutritious food in your body, you're hydrating well, all of that holistic approach to yourself, that's going to help you deal with things better. It's not necessarily going to make the hot flashes go away, but it's going to maybe make you notice them a little less, or maybe they'll be a little less severe. But I don't know of any, but now you've tempted me to go look and see if there are any new studies out looking at that. The effect of exercise on because the funny thing about hot flashes is it's all how you perceive them, right?
True. Yeah. And then lastly, pads are better for you or safer for you than tampons or Diva cups or other types of menstrual care.
Not necessarily. And I think the big fear with tampons came about, I don't know if it was the 70s or the 80s when we began to realize there was this phenomenon called toxic shock syndrome, that could
Yeah.
occur if you leave a tampon in too long. So the trick is this: when you go pee, take your tampon out and put another one in. If you're only leaving your tampon in for a
Right.
few hours at a time, or even overnight, like overnight tampon use is okay, but don't forget you have a tampon in and shove another one in, right? I mean,
Right.
that's the trick. And if you leave a Diva cup in, you leave it in for a few days, it's probably not that big of a deal. I mean, they're just the same cervical cap. It's like, kind of like a diaphragm that we used to use back in the day for birth control, right?
Right.
But you don't want to leave those in too long, because whatever fluid gets collected in there, depending on what bacteria can get in there, can absolutely
Right.
develop into an infection. And then if you don't treat it, it can be absorbed through your vaginal mucosa and can make you really, really sick.
Wow.
So yeah.
Wow.
So just change them out,
Wow.
ladies.
Yeah. Well, this has been so interesting, and I feel like I have a million more questions. Each answer you gave me stemmed I came up with 5 more questions I had. So I feel like we may have to do a second one of these.
Okay.
And I look forward to that if you are willing to join us again, hopefully soon. And thank you again. And I hope to see you soon. Happy New Year, Elizabeth.
Thank you. It's been my pleasure, and Happy New Year to you as well, Maville. Take care.
Thank you so much. Take care.